Laparoscopic liver resection for hepatocellular carcinoma. Hepatocellular carcinoma is the most common form of liver cancer. It's an aggressive cancer, most common in people with advanced liver disease. In the beginning, hepatocellular carcinoma grows slowly. Surgery to remove the tumor or a liver transplant can treat HCC in its early stages. Laparoscopic liver resection is a minimally invasive surgical technique used to remove cancerous tissue from the liver, including in cases of hepatocellular carcinoma. It offers several advantages over traditional open liver resection, such as faster recovery, shorter hospital stays, and reduced pain. This is a case of 70-year-old female who is known hypertensive and have chronic liver disease due to HCV. She presented with complaints of on and off nausea. Clinically, patient was asymptomatic. On ultrasound, cirrhotic liver and an exophytic lesion in segment 6 were found, and she was having cholelithiasis. In her CT scan, liver shows cirrhotic morphology and irregular margins, 44 by 47 millimeter lesion in segment 6 of liver with arterial enhancement and washout suggestive of hepatocellular carcinoma, and cholelithiasis with no biliary duct dilatation, portal vein normal, no ascites, and no enlarged lymph nodes. Her labs are shown as follows. Case was discussed in MDT and plan of TACE. Surgical resection or transplant were discussed with patient and family. They opted for laparoscopic liver resection of tumor. This is a cirrhotic liver with multiple adhesions of liver capsule with abdominal wall. Now, beginning the procedure. The first step involves anchoring the falciform ligament to the anterior abdominal wall using sutures. Next, we perform adhesiolysis between the liver and the abdominal wall to mobilize the right side of the liver. Careful dissection helps in safely exposing the tumor located in segment 6. This is an exophytic tumor located peripherally, making it amenable to minimally invasive resection. We are taking peritoneum along with our dissection to achieve a tumor-free margin. We now begin the cholecystectomy. The gallbladder is carefully dissected from the liver bed after confirming the critical view of safety at the cystic duct and artery. Cystic duct and artery are clipped and transacted. We will leave gallbladder in place for now and remove it later. To control inflow bleeding during parenchymal transection, we apply the Goldfinger device across the hepatoduodenal ligament, performing a vascular inflow occlusion known as Pringle's maneuver. A nylon tape is passed through it and held in port of control. In case the first Pringlage fails or needs replacement, a backup Pringle maneuver can be performed by placing a Foley catheter around the hepatoduodenal ligament. This allows temporary occlusion of the portal triad when needed. With preoperative imaging guidance from CT and intraoperative ultrasound, we can now demarcate the resection line on the liver surface using electrocautery, shown by arrow here. A margin of at least 1 centimeter around the tumor is ensured to achieve clear, tumor-free margins. We took more margin than recommended. Superficial dissection begins along the marked resection line using a ligature device. The cholecystectomy is completed by removing gallbladder from its bed. The gallbladder is temporarily kept aside and will be removed at the end of the procedure along with the specimen. We now proceed with deeper parenchymal dissection using the harmonic scalpel. This device allows precise cutting and coagulation, minimizing blood loss, while progressing through the liver tissue toward the tumor. Dissection continuous with ligature and harmonic scalpel. This allows for efficient sealing and division of small vessels and bile ducts. Perfect hemostasis is key to perform these procedures laparoscopically. We can also use diathermy or other energy devices for parenchymal dissection of liver. As we complete the liver dissection, meticulous hemostasis is achieved using the harmonic device. Any visible bleeding points or bile leaks are carefully controlled to ensure a safe and clean operative field. The resected specimen, including the tumor and gallbladder, is placed into a laparoscopic retrieval bag to prevent spillage. It is then extracted through a small extension of the umbilical port site. Finally, a single closed suction drain is placed in the subhepatic space to monitor for any post-operative fluid collection. This concludes the laparoscopic liver resection for hepatocellular carcinoma. The abdomen is desufflated and all ports are removed under direct vision. The patient tolerated the procedure well. This is the tumor we removed. These are original pictures of specimen, showing superior surface and resection margin. Pringle time, less than 10 minutes. Blood loss, less than 100 milliliters. Total surgery, time 2.5 hours. Post-op hospital stay, 3 days. Post-operative care includes monitoring of liver function and drain output, followed by early ambulation and diet resumption. Final histopathology reports: moderately differentiated hepatocellular carcinoma, parenchymal resection margin free of tumor, liver cirrhosis, and chronic cholecystitis.